Treatment of slipped capital femoral epiphysis, SCFE. Slipped capital femoral epiphysis, SCFE, is a disorder of adolescence in which the growth plate is damaged and the femoral head slips down and backward off the neck of the bone at the growth plate, the weaker area of bone. In a previous video, I explained what SCFE is, its causes, symptoms, types, and how it is diagnosed. In this video, I will talk about treatment, recovery, and the most important complications. The treatment of SCFE is operative stabilization once it is diagnosed. Children with SCFE should be made non-weight-bearing and should receive prompt consultation with an orthopedic surgeon. Patients with acute unstable slips should be admitted to the hospital for treatment at initial presentation. Hospital admission and bed rest may also be necessary for patients with bilateral SCFE, whether acute or chronic. The operative goals are stabilization of the diseased physes to prevent further slippage and avoidance of complications. In extreme cases, it is important to perform surgery on the day of diagnosis. However, most slips are stable and can wait 3 to 14 days for operative treatment. The gold standard for stabilization of chronic, stable slips, regardless of severity, is the use of a single cannulated screw placed in the center of the epiphysis. In this procedure, the surgeon passes a screw percutaneously from the side of the top of the femur, through the neck of the femur, through the growth plate and into the ball section of the femur. The screw keeps the ball section of the femur from slipping out of place. Some surgeons prefer using Kirschner wires, as they claim that screws can increase the risk of premature physes closure and can interfere with proximal femur remodeling, results in growth disorder. Stabilization usually involves pinning in situ without attempt at reduction because manipulation has been found to correlate with a poorer long-term prognosis. In situ fixation, pins or screws through the physes, has a relevant role in stable slips, unstable slips with less than 30 degrees of deformity, and in contralateral normal hips, prophylactically. Prophylactic pinning of a radiographically and clinically normal hip should be reserved to a selected group of patients, such as very young children, presence of endocrinopathy, obese patients, and those whose follow-up is thought to be difficult. Nowadays, consensus about routine prophylactic pinning is increasing, since the complication rate associated with the procedure is considered lower than that associated with the development of contralateral disease. Slips greater than 30 degrees necessitate an anatomical realignment to restore hip anatomy and to reduce the risk of avascular necrosis. It may be affirmed that the open reduction is safe and efficient. The doctor may first make an open incision in the hip, then gently reduces the head of the femur back into its normal anatomic position. Then inserts metal pins to hold the bone in place. This procedure is called surgical hip dislocation, modified Dunn procedure. Any close reduction of a high slip should be avoided, as they increase the rate of interruption of the blood supply. Postoperative recovery. The doctor will discuss your child's expected time to full recovery. It's unique to each child and depends on many factors including severity of the slippage and type of surgical procedure done. In general, the child will need crutches or a walker for up to about 4 weeks after surgery for stable slips, and for at least 6 to 8 weeks for unstable slips. After this period, crutches are discontinued, and regular activities are gradually resumed. The child will work with a physical therapist to help strengthen leg and hip muscles and improve range of motion. Depending on the severity of the slippage, most children may return to sports about 6 months after surgery. However, we recommend not allowing a return to contact sports until the growth plate has closed. The child will return to the doctor for follow-up visits for 18 to 24 months after surgery. These visits may include X-rays every 3 to 4 months to ensure that the growth plate has closed and that no complications have developed. The growth plate does not heal within several months, and the original unstable situation persists until the growth plate is closed. Given the risk of progression of the slip, the fixation of the slipped epiphysis of the hip can only be removed after closure of the growth plate. All children with unilateral involvement who do not undergo prophylactic pinning should be followed closely by an orthopedic surgeon to prevent delay in diagnosis of the second slip. The patient should be scheduled for repeat examinations of the contralateral hip during the first 1 to 2 years after initial diagnosis. Close follow-up should continue until the child has finished growing. In addition, patients and parents should be instructed to seek medical attention immediately if they experience any symptoms of SCFE. Complications: avascular necrosis, AVN. In severe cases, SCFE may interrupt the blood supply to the femoral head. This can lead to a gradual and very painful collapse of the head, a condition called avascular necrosis, AVN, or osteonecrosis. AVN is sadly quite a common and often unavoidable complication in SCFE. When the bone collapses, the articular cartilage covering the bone also collapses. Without this smooth cartilage, bone rubs against bone, leading to painful arthritis in the joint. Because evidence of AVN may not be seen on an X-ray until 12 to 18 months after the initial surgery, the patient will need to be monitored with X-rays throughout this period of time. Factors related to the development of AVN include unstable hips with separation of the epiphysis from the metaphysis, delay from presentation to surgery, severity of the slip, younger age, short duration of prodromal symptoms, and it can be a complication of operative pinning. Chondrolysis. Chondrolysis is a rare but serious complication of SCFE. In chondrolysis, the articular cartilage on the surface of the hip joint degenerates very rapidly, leading to pain, deformity, and permanent loss of motion in the affected hip. Chondrolysis can occur with an untreated SCFE or develop postoperatively. It is present in up to 2% of cases even before treatment. Impingement. SCFE may also cause impingement within the hip joint as a result of changes to the shape of the femur. Impingement with hip pain and/or limited range of motion may develop, requiring additional surgery. All teens are at increased risk of developing premature development of osteoarthritis, regardless of the degree of slip.